challenging behavior which involves some degree of direct physical force to limit or restrict movement or mobility. The use of physical restraint should only be used as a last resort and where alternative interventions to de-escalate the situation have failed. The aim of this module is to identify and discuss measures that may be implemented to reduce assaults and potentially violent incidents to a minimum. It will enable staff to recognize different aspects of conflict that they may encounter and to raise awareness and provide an understanding of the different methods to be employed in resolving conflict. Disclaimer. This module provides the theoretical element of the core subjects discussed only. Those with practical elements required, such as physical restraint techniques, are required to undertake a practical training course. i.e., training is not a substitute for hands-on or practical training and must not be used as such. As a supplier of e-training only, any additional training required for competency, including practical physical restraint training/MAPA, is the responsibility of the agency, candidate and client to arrange. Work-related violence is a complex risk to manage because of the many factors that can contribute to escalation and possibly physical assault. Some of these factors can be controlled with appropriate conflict management and handling violence and aggression training. However, there are circumstances where de-escalating a situation just isn't enough and requires physical intervention to control a potentially dangerous situation, imposing risks to service users and staff. The purpose of this policy is to provide guidance to health and social care staff on the prevention of violence, threats of violence, aggression and how to deal with such incidents. Further training may be required in the practical skills on effective physical restraining of aggressors, where a potentially dangerous situation arises. Before using any form of restraint, risk assessments should be conducted to assess the potential risk of aggressive behavior and types of environments, conditions that can trigger threatening and challenging characteristic. The risk assessment should include the following: patient's normal day-to-day behavior, patient's underlying condition and treatment, where a person has a known history of violence and aggression and if following an up-to-date risk assessment. Clear documentation in the records should state explicitly under what circumstances restraint may be used. That suitable safeguards are placed within all tertiary interventions procedures, that is aftercare, health monitoring. Definition of violence. The term violence covers a wide range of incidents, not all resulting in injury. The Health and Safety Executive defines violence as any incident in which a person working in the healthcare sector is verbally abused, threatened or assaulted by a patient, member of the public or a member of staff arising out of the course of their work. Individual responsibilities. All health and social care staff have a responsibility to cooperate with the measures provided for their safety, both in terms of the risk assessment process and the development and implementation of control arrangements. Employees should attempt to minimize a potentially violent situation by withdrawing from the situation if the opportunity arises or alerting appropriate personnel to come to their aid and, where necessary, restrain the individual from causing further harm to themselves and others. Factors which influence violent incidents. It is widely recognized that changes to environment and routine can trigger aggressive behavior as well as deterioration of one's health. Below is a list of contributory factors that can have an influence on a service user's behavior. Possible underlying medical causes to consider are anxiety or distress, mental illness, for example dementia, schizophrenia, delirium, acute confusion, due to infection/pyrexia, hypoxia, electrolyte or metabolic imbalance, pain or discomfort, constipation, dehydration, hypertension, drug dependency or withdrawal, including alcohol, nicotine, sleeping tablets and illicit drugs, brain insult, injury, reaction, side effect of medication, intoxication, due to alcohol, drug overdose or drugs of abuse, pregnancy and postnatal conditions, communication, religious and cultural issue, attitude and interpersonal skills, Aggressors may have a perception that their individual needs are not being considered, and not being treated with dignity and respect, or their human rights are breached, feel they are being patronized or simply misunderstood. Environment. Physical factors in the environment may contribute to violence and frustration, leading to aggression. These may include such things as inadequate space, aggravating noise, overcrowding, shabby environment, lack of supplies such as pillows, blankets, etc. Risk assessments. All employers are legally required to assess the risk of violence as they would any other workplace hazard, as well as assessing the risk regarding violence in the context of health and safety. Healthcare organizations have a responsibility and duty to their staff and service users to assess risk in the context of the clinical services provided. The threat of violence must be mitigated in the promotion of crime and disorder prevention, public safety, public nuisance, and the protection of vulnerable adults and children in healthcare premises. Essentially, this emphasizes that when using restraint, a balance must be achieved between minimizing risk of harm or injury to the patient and others, but by maintaining the dignity, personal freedom, and choice of the patient. Planned risk assessment. A planned assessment should be undertaken and reviewed at set intervals in accordance with the health authority body's policies on risk assessments. It is important that all employers clearly set out responsibilities in terms of who undertakes what level of assessment, how and when. Recording systems and tools need to support processes that are implemented and must be effective in distilling key management information in relation to the risks of violence and, where necessary, evidence the need for further improvements. Controls. The risk assessment needs to consider the risks relating to service users. Although most individuals with mental health issues or learning disabilities present little risk to staff, there are times when they may be particularly confused and vulnerable, and present a risk to themselves and occasionally others. It is imperative that all staff are provided with guidance on the appropriate methods of communication and interpersonal skills when managing vulnerable groups, and are provided with the relevant resources such as care plans in helping to understand the individual needs of the patient. Doing so promotes a positive impact on how they respond and deal with difficult situations. Patient-specific risk assessments. Patient-specific risk assessments should be completed or reviewed if the patient has a history of unpredictable, challenging, violent or aggressive behavior. The patient displays challenging, violent or aggressive behavior. An incident occurs or a patient, relative or visitor becomes aggressive. The patient-specific risk assessments will consider the following: the mental, emotional, and physical condition of the patient, the patient's behavior related to his or her medical conditions or recent ingestion of drugs, alcohol, or medicines, any current stress factors or triggers that may have contributed to their current state of health, any historical evidence of challenging, violent, or aggressive behavior. Does the person consider you a threat? The hazards identified following assessment must be recorded in the patient's care plan, and this information to be relayed to all members of the multidisciplinary team who are likely to be involved with the patient. This should include all staff, not just medical staff. For example, domestics, physiotherapists, occupational therapists, dietitians, etc. Dynamic risk assessment. This involves staff using a dynamic risk assessment immediately before an incident occurs or while it is occurring. A dynamic risk assessment can be defined as a continuous process of identifying hazards and risks and taking steps to eliminate or reduce them in the rapidly changing circumstances of an incident. The dynamic risk assessment involves staff being alert to warning signs as covered in conflict resolution training, carrying out a 10-second risk assessment. If staff feel there is a risk of harm to themselves, they should leave immediately, placing themselves in a position to make a good escape, making a judgment as to the best possible course of action. For example, whether to continue working or withdraw. Utilizing appropriate physical security measures, for example, triggering panic buttons to call assistance from staff nearby /security /the police, or using a lone worker alarm device. Ensuring that when they enter a confined area or room, they make sure they can operate the door lock in case they need to make an emergency exit. avoiding walking in front of a patient, service user, and not positioning themselves in a corner or in a situation where it may be difficult to escape. Remaining calm and focused during an incident in order to make rational judgments. At no point should a staff member place themselves, their colleagues or patients, service users at risk or in actual danger. Patterns of behavior. Understanding a patient's behavior and responding to individual needs should be at the center of delivering patient care. All patients should be assessed comprehensively to establish what sort of therapeutic behavior management might be of benefit in the event of a crisis. This should involve identifying the underlying cause of the behavior, agitation, wandering, absconding, etc., and deciding whether the behavior is preventable or if intervention, medical or physical, is necessary to safeguard the service user and those within close proximity. A person's behavior in response to a perceived stress can vary enormously. However, certain patterns of behavior are common and if recognized early can be curtailed or their effects lessened. Clearly, compliance is the ideal behavior, whereas aggressive or aggravated resistance would be a behavior that should be avoided. The ability to recognize warning signs is vital to maintain and protecting personal and patient safety. Listed below are a selection of signs that may be displayed when a person is becoming more frustrated or aggressive. Warning signs/danger signs. Direct, prolonged eye contact, fist clenching, standing tall, lips tighten over teeth, exaggerated movements, hands rise above the waist, breathing rate increases, shoulders tense, quick movements, stance moves from square to sideways, shifting weight from one foot to the other, facial color may pale. Where warning signs are observed, it may still be possible to intervene and attempt to diffuse the situation. However, precautionary measures need to be in place in the event of unpredictable behaviors and where an individual's actions may escalate to a more dangerous level. In the event where there is a risk of dangerous behavior developing, it is recommended that you withdraw any measures in place at the time and seek assistance from senior staff and/or security staff and in extreme circumstances, the police. Preventative measures for the reduction of violent incidents. The layout of working areas and work routines can reduce all risk of violence. However, when it becomes apparent that a patient, visitor or member of the public is becoming violent, the response of staff involved may limit the consequences. Below are some key points focused on reducing the prevalence of the problem by minimizing known or suspected risk factors and by early intervention, that is when violence is perceived to be imminent or immediately post-incident. This knowledge can be used proactively to plan positive interventions such as training staff to recognize warning signs and escalation strategies so they could diffuse a potentially violent incident. Remain calm. Try to avoid invading their personal space. Avoid sudden movements or actions. Speak calmly and firmly without raising voice. Reassure the agitated person of their safety. Send for assistance quickly and discreetly. Move calmly to a standing position, balanced and ready to move. If possible, try to walk in direction of an open door as a means of escape, but behind any available barrier such as a chair or table. Determine the cause of concern and offer to help if possible. Understanding and sympathy can reduce violence. Do not argue or give orders. Emphasize, I know you have a problem. Try to move potential weapons if safe to do so. There may be patients who are known to become aggressive and staff may also be aware of relatives, visitors who have displayed violent tendencies on previous occasions. It is essential that any incidents of violence is recorded and that in these instances a system is in place to effectively communicate this information to others in order to take the necessary steps to protect themselves from the risk of assault. Physical intervention. Physical restraint intervention involves direct physical contact by one person against another with the intent to prevent the person's freedom of movement. Such restraint should always involve the least restrictive practice and only be carried out by those trained in the restraint technique being employed and in accordance with the restraint procedure for the individual. In high-risk areas, including the emergency departments, the use of physical techniques may need to be used as an acceptable means of intervention. These areas would normally have staff on site that have undertaken appropriate managing actual and potential aggression, MAPA, training to support the staff in the high-risk areas with the use of physical restraint. Health and social care staff should have undergone appropriate practical training to anticipate behavior that is challenging and how to manage violence, aggression, and extreme agitation, including de-escalation techniques and methods of physical restraint. Restrictive physical interventions that employ force should only be used when other strategies have failed and the following processes are adhered to. In an emergency situation when the risk of inaction outweighs the risks of restraint, with the minimum amount of force for the shortest duration of time, in the best interest of the service user and or to prevent harm to third parties, by staff that have received specialist training and employ only the techniques for which they have received a preparation for practice, employer responsibility, in a way that minimizes the risk of physical injury and loss of dignity, ensuring avoidance of contact that could be construed as sexual, with subsequent debriefing for staff and, where possible, the service user, with formal recording and reporting of the incident. Restraint should only be used as a last resort and only when alternative methods of therapeutic behavior management have failed. Its use should be proportional to the risk of the situation. The method used should be the least restrictive and be effective and safe. Inappropriate use of restraint may be viewed as a form of abuse, therefore it is paramount that all other interventions have been considered before considering its use. Restraint is clinically and legally justified in certain situations and can include where the client gives informed and voluntary consent as part of a planned program of care, where the carer, clinician has a professional duty of care to restrain a client in order to protect that client from a greater risk of harm, to avoid a foreseeable risk of harm occurring to others, where non-physical methods have failed or the incident is of such significance to warrant immediate action. The most senior trained member of staff in control of the incident may decide to restrain the patient physically. In doing so, the following rules should be borne in mind. 1. Make a visual check for weapons. 2. Nominate staff members to assist in control and allocate each a specific task. 3. A large number of staff grabbing at people can be counterproductive. 4. Fewer, but well-briefed staff are likely to be more effective. 5. Aim at restraining arms and legs from behind if possible. Seek to immobilize swiftly and safely. Joints should not be moved or held contrary to a natural bend. 6. Constantly explain reason for action and enlist support from the patient for voluntary control as soon as possible. 7. Avoid neck holds. 8. Avoid excess weight being placed on any area, but particularly stomach and neck. 9. Do not slap, kick or punch. Staff should monitor throughout any intervention for signs that the individual is struggling to breathe. The warning signs may include gurgling, gasping sounds, verbal complaints or difficulty speaking, an increased effort to struggle or distress, anxiety. A violent and loud person suddenly changes to a passive, quiet and tranquil one. Pale/grey/blue skin coloring to the lips, nail beds or earlobes, then the face and other parts of the body. Do not assume that just because an individual is snoring that he or she is sleeping. Positional asphyxia. Restrained positions that increase the risk of positional asphyxiation, for example, prone restraint, must only be used if safer methods, for example seated and supine, are likely to fail. Prone restraint must only be used for the shortest time possible to manage the situation presenting and the patient's physical state, including airway management, breathing and circulation, must be monitored both during and after such intervention. Weapons. If it is thought that a patient may be carrying a weapon, do not attempt to disarm the patient. Those present should attempt to keep the situation contained. Staff should ask the individual to surrender the weapon and move to another vicinity. If the individual will not put the weapon down, staff should evacuate themselves and others to a safe area and dial 999 for police attendance. Never ask someone to hand a weapon to you directly, as this may result in injury. Police will be equipped appropriately with shields and vests for their protection. Methods of restraining behavior. NICE Guidance NG10. Manual Restraint, Section 1.4.2. Health and social care provider organizations should ensure that manual restraint is undertaken by staff who work closely together as a team, understand each other's roles, and have a clearly defined lead. When using manual restraint, avoid taking the service user to the floor, but if this becomes necessary, use the supine, face up position if possible, or if the prone, face down position is necessary, use it for as short a time as possible. Do not use manual restraint in a way that interferes with the service user's airway, breathing, or circulation. For example, by applying pressure to the rib cage, neck or abdomen, or obstructing the mouth or nose. Do not use manual restraint in a way that interferes with the service user's ability to communicate. For example, by obstructing the eyes, ears, or mouth. Undertake manual restraint with extra care if the service user is physically unwell, disabled, pregnant, or obese. Aim to preserve the service user's dignity and safety as far as possible during manual restraint. Do not routinely use manual restraint for more than 10 minutes. Consider rapid tranquilization or seclusion as alternatives to prolonged manual restraint, longer than 10 minutes. Ensure that the level of force applied during manual restraint is justifiable, appropriate, reasonable, proportionate to the situation, and applied for the shortest time possible. One staff member should lead throughout the use of manual restraint. This person should ensure that other staff members are able to protect and support the service user's head and neck, if needed. Able to check that the service user's airway and breathing are not compromised. Able to monitor vital signs. Supported throughout the process. Staff attending a violent incident must make the decision as to what level of restraint is required. The number of staff required to resolve a violent incident directly should be the reasonable number necessary to restrain the individual, whilst minimizing the risk of injury to all parties. One member of staff should lead the team and assume control of the person being restrained throughout the process. He or she should ensure that the restrained person's head and neck is appropriately supported and protected, and airway and breathing are not compromised. In a situation where a nurse or other person is being attacked or is at risk of physical harm, it is possible to justify the use of restraint as self-defense. Principal risk factors that can contribute to death during restraint can include the body position of a person results in a partial or complete obstruction of the airway and the subject is unable to escape from that position. Pressure is applied to the back of the neck, torso, or abdomen of a person held in the prone position. Pressure is applied which restricts the shoulder girdle or accessory muscles of respiration while the person is lying down in any position. The person is obese, particularly those with large stomachs and abdomens. The person is of small or light build. Alcohol or drug intoxication, especially stimulants, for example, cocaine, being on antipsychotic medication. Some medications under certain conditions can cause abnormal heart rhythms. The person has a heightened level of stress. Staff should note that the effects of a violent struggle or restraint and buildup of lactic acid can exacerbate the effects of drugs, alcohol, or medication. When any event of restraint technique is used, this should be documented in the patient's notes giving specific reference to the technique and the rationalization for the method being used, that is breakaway, deflection, de-escalation, physical, environmental, chemical, mechanical, including whether this was planned or unplanned, as well as the name of the person this has been escalated to. A clinical incident, DATEX, risk event form should be completed to report any incident of physical and/or chemical restraint. Both the DATEX and patient notes should provide details on what communication and information the patient and their families, as appropriate, have received following restraint implementation. Staff training. The most crucial element of the control strategy is adequate and appropriate staff training. All physical skills trainers should adhere to the following professional code of practice. The instructor will always emphasize the rights of service users. The instructor will always stress the importance of preventative strategies such as customer service, empathy, communication skills, positive behavioral management techniques, calming and de-escalation techniques, timeout and other non-physical intervention before considering physical intervention. The instructor will always stress the importance of operating within the spirit of organization's policy and values. The instructor will always stress the importance of responding lawfully to any incidents arising, including reference, where appropriate, to sector-specific regulations and guidance. The instructor will always teach physical intervention strategies within the context of a technique of last resort. The instructor will always emphasize the importance of utilizing appropriate physical intervention techniques. The instructor will always emphasize the importance of using the gradient of control or a progressive/behavior-led model. The instructor will always emphasize the importance of reducing or removing the physical intervention at the first safe opportunity. The instructor will always stress the importance of adequate and appropriate aftercare. The instructor will always stress the importance of management strategies, including planning, monitoring, and review. The instructor will complete a systematic review of delegates' learning and skill retention. You should now have a clearer understanding of the risks that exist and the practical steps that can be taken to effectively manage and minimize risks imposed to service users, staff, and other persons present. Remember, the best way to manage the risks associated with physical intervention is to avoid it, but when it is necessary, the steps that have been outlined in this course are a very big and positive step towards intervening safely. Note: health and social care staff should have undergone appropriate practical training to anticipate behavior that is challenging and how to manage violence, aggression, and extreme agitation, including de-escalation techniques and methods of physical restraint.
Questions and answers: reducing restraint in health and social care. Question 1. To prevent falls, all of the following should be done, except provide them with nurse alert buzzer, keep area free from clutter, position the patient in the deep chair, that's the correct answer, and provide handrails. Next, question 2. Trying alternative methods. A. Helps to prevent the use of restraint intervention. That's true. Others is illegal. B. C. Should be the same for every patient. C. And D is useless. The next question, 3. Restraint intervention is illegal and should never be considered. True or false? The answer is false. Next question, question 4. Beneficence is defined as which of the following? 1. To support, respect, rights to self-determination. That's correct. To treat patients fairly and equally. 3. The intent to cause no harm. 4. The intent to do good for the patients. Next question, question 5. Which legislation lays down the 5 principles that relate to the protection of capacity? 1. Human Rights Act 1998. 2. Equality Act 2010. 3. Mental Health Act 1983, amended 2007. And 4, Mental Capacity Act 2005. The correct is Mental Capacity Act 2005. Next. The previous question, beneficence, the answer is the intent to do good. Intent to do good. That is beneficence. That's the correct answer. So it's not self-determination. That is autonomy. 6. Restraints are used for which of the following reasons? 1, to keep patients safe from harm to self or others. That's correct. 2, when patients are confused. 3, when a patient refuses treatment. 4, when wards are short-staffed. Next question. 7, autonomy is defined as which of the following? The intent to cause no harm. 2, to treat all patients fairly and equally. 3, support and respect rights to self-determination. That's correct. 4, the intent to do good for the patients. Correct one is to support or respect rights to self-determination. Question 9. Person 8. A patient hospitalized following a stroke becomes disorientated at times and tries to get out of bed, but is unable to ambulate without help. Which of the following is an appropriate action? 1, sedate the patient. 2, use a safety monitoring device which alerts staff when patient has got out of bed. That is correct. And 3, restrain the patient to the bed. The correct is use a safety monitoring device which alerts staff when patient has got out of bed. Question 9. Restraints should be used on all elderly patients. True or false? That is false. Question 10. Which of the following is not a form of mechanical restraint? 1, bandaging hands to size of body. 2, sedation. The correct answer is sedation is not a form of mechanical restraint. 3, cord size, raise on bed. 4, removing walking aid from the patient. That's the end of the questions and answer.